Welcome to Pathology Central Key Concepts. The topic of this video is lysosomal storage diseases. Now, these are very rare diseases, and there are about 70 of them. And so if you were going to try to memorize all of the different types of lysosomal storage diseases and all the enzymes involved, it would be really overwhelming. So my goal in this video is not to go through a series of different diseases and try to give you facts that you can memorize, but to provide a framework to help you understand why the lysosomal storage diseases present the way they do and what the defects are. So let's begin by reviewing the function of lysosomes and then try to focus on the pathophysiology of lysosomal storage disorders. So lysosomes are the stomach of the cell, the intracellular digestive system. They have a variety of different hydrolytic enzymes that catalyze the breakdown of complex macromolecules. Now, lysosomes are involved in a number of different processes. One is autophagy, and this is when the cell is recycling its own organelles and proteins in the setting of nutrient or growth factor depletion. What happens here is a lysosome is going to fuse with the autophagosome and then digest those materials and recycle those metabolites. Heterophagy is another role of lysosomes, and this is what we see when we have phagocytes such as a macrophage or a neutrophil engulfing a microbe or a piece of debris. That now needs to be destroyed, and that will occur through fusion with the lysosome. And lysosomes also play a role in membrane repair by fusing with the plasma membrane. So let's take a look at autophagy. This is a really important process, and in fact was so important it was the subject of a Nobel Prize. The actual process, which I show here in this very beautiful image, is pretty straightforward. The cell senses nutrient depletion or depletion of growth factors through cytoplasmic sensors, which then stimulate a number of genes, autophagy-related genes, making proteins. And this is going to cause a membrane to form around the cytoplasmic organelles to be digested. It basically forms a little bubble and will fuse with the lysosome, causing degradation of the materials within and recycling of our metabolites. So pretty straightforward. As I mentioned, this is a survival mechanism when nutrient deprived or growth factor depletion, and we can see this process come into play in atrophy, in ischemic injury, and infection, as I already mentioned. But I also said it plays a role in a variety of other issues as well, such as aging and in neurodegenerative diseases. Now, it's believed that autophagy is one of the challenges that faces cells in Alzheimer's disease. So we're going to be digesting complex molecules, and I'm going to show you a bunch of different substrates and enzymes, and I want to give you just a little bit of background about what these molecules are. And so they're not just words. I'm not going to show you the biochemistry of them because I would find that overwhelming myself, and it's really not necessary. But the thing that you need to understand for many of these diseases is that what we're looking at breaking down would be gangliosides and sphingolipids, which are very common in the central nervous system, which is why many of these diseases have central nervous system effects. So gangliosides, just what is a ganglioside? It is a glycosphingolipid. A glycosphingolipid is composed of ceramide, which is, cera means wax, and this is your amide group here, plus a sugar, oligosaccharide, and an acid, sialic acid. So that's a ganglioside. And as the cells cycle through, they need to break down molecules, generate new metabolites. It's a constant process that's going on. What is a ceramide? Sphingosine and fatty acid. And this is the basic unit of our sphingolipids. What are sphingolipids? They're membrane phospholipids. And then another term you'll see is a sulfatide. That is just a lipid that contains sulfur. The last entity I'll talk about in this video has to do with a glycogen metabolism issue. This is one of the glycogen storage diseases. It's Pompe disease, but it's also considered a lysosomal storage disease because this is a lysosomal enzyme which is deficient in that disease. So we'll talk about that at the end. Now, the next slide I'm going to show you is going to look very complicated, but don't be overwhelmed. This is looking at the metabolism of a variety of complex molecules in the central nervous system. So we have here our GM1 ganglioside. There's an enzyme here which is important for catalyzing the metabolism to yield GM2 ganglioside. We next have another enzyme. This is hexosaminidase A, which takes us to GM3 ganglioside. And the whole goal of these is to take us to ceramides, because ceramides are a basic building block that can then be incorporated into a variety of different macromolecules. So as you know, in the body, we're constantly breaking down and building, breaking down and building. So we're breaking down from complex molecules like sulfatides, gangliosides, sphingomyelin to yield something which is more basic, ceramide, which can then be recycled into all these macromolecules. So as I mentioned, the lysosomal storage diseases are pretty rare, 1 in 2,500 live births, about 70 described disorders. Almost all of them are autosomal recessive transmission, which makes sense because we're talking about enzymes. And remember that for every gene we have 2 alleles, and if you knock out one allele for an enzyme, because they're so efficient, having just half as much enzyme is generally enough to keep things ticking over. But you have to knock out both, so autosomal recessive. We can also see X-linked recessive transmission. This is because the body is constantly building up and breaking down molecules. This is going to present very early in life. So many of these diseases will present in infants and children. The central nervous system is frequently involved, and part of that has to do with the breakdown of these particular complex molecules, the gangliosides, etc. And then what is it that causes the cellular dysfunction? And we're looking here at all of the lysosomal storage diseases. So these are just the main characteristics. So one is going to be the storage of undigested material. So you have all of these substrates that can't be broken down that are just building up in the lysosome. So that's going to cause lysosomal dysfunction. But not only that, but we're going to have secondary effects. So macrophages are going to be activated, and this is going to cause the release of cytokines, and all of that is going to stimulate a lot of different processes. So the organs and distribution of these different diseases depends on 2 factors. One, where is the degraded material found? So gangliosides are in the brain. That's why we see when we have defects in these enzymes, it's going to have central nervous system effects. The other issue is, where does degradation occur? So in the gangliosides in the brain, the degradation also occurs in the brain. But for other systems, we see that it's the mononuclear phagocytic system that is responsible for picking up debris and for addressing these issues. And the mononuclear phagocytes have a lot of lysosomes. They tend to accumulate in the liver and the spleen. So for example, in Hurler syndrome, we'll see hepatosplenomegaly. So hepatosplenomegaly is something we can commonly see in lysosomal storage disorders. So what is the mechanism by which these diseases cause disease? So if you have an inherited deficiency of a functional lysosomal enzyme, you'll get incomplete catabolism of the substrate, which will then accumulate. This is called primary accumulation. We'll get enlarged numerous lysosomes, and these large organelles are going to interfere with the normal cell function. The other issue brings us back to autophagy. So remember, one of the roles of the lysosomes is to deal with sort of defunct organelles. So this in particular is important with the mitochondria, because as mitochondria become leaky or have issues, they can cause release of reactive oxygen species, and that can cause injury. So this is where we have secondary accumulation of autophagic substrates, such as alpha-synuclein and Huntington protein. And this is something that we're going to see when we talk about neurodegenerative disorders. So I've already shown you this image. It's going to look a little bit more complicated, so steel yourself. Here we go. All right, so this is looking now not just at our metabolism with our enzymes, but the various diseases, they're here in pink, that are associated with deficiencies of these particular enzymes. So if you are lacking your hexosaminidase A function, you will get Tay-Sachs disease. And I mentioned here just the alpha subunit because that's the one that is mutated in Tay-Sachs. Most instructors aren't going to require you to cone down to that degree of detail. There are alpha and beta subunits of hexosaminidase A. There's another disease called Sandhoff disease that looks very similar to Tay-Sachs, and it's due to mutations in the alpha and beta subunit. So the way to look at this is that if you look at this particular pathway, that if you have a blockage, so this red line is indicating a blockage, so the deficiency of this enzyme, whatever is upstream is going to accumulate. So in GM1 gangliosidosis, we're going to have accumulation of GM1 gangliosides. In Tay-Sachs disease, we're going to have accumulation of GM2 gangliosides, and so on. So in metachromatic adrenoleukodystrophy, accumulation of sulfatides. This is due to an aryl sulfatase A deficiency. So as you can see, we don't ever see patients who have multiple enzymes that are knocked out. So this is not to be thought of in that way. It's just showing you what each pathway would look like. So I think this is a good way to organize your thoughts and understanding what it is that we're trying to accomplish, which is trying to break down to ceramide. I've also created a table. This is based on tables from Pathologic Basis of Disease, Essential Pathology, and Robbins and Kumar Basic Pathology, as well as some information from Up to Date. Because I think this is a nice summary of the disease, the deficient enzyme and protein, the metabolite that accumulates, and what the clinical features are. Now keep in mind that because there can be a variety of different mutations, some of these diseases are more severe, some of these mutations cause more severe disease, etc. So you don't always see all of these clinical features in any individual patient. So with that background, let's take a look at what happens in a healthy lysosome and then what happens in a lysosome that is lacking an enzyme. So here we have our complex substrate. This could be, for example, our GM2 ganglioside, which ordinarily is incorporated into the lysosome. Enzyme A is going to break this down, letting these little blue small diffusible end products out. Enzyme B is going to do the next part, taking out these little yellow molecules, moving us down to here. And then enzyme C is going to release these small green compounds, which can then just diffuse out of the lysosome. The lysosome ordinarily is going to fuse with an autophagosome, which we can see here. It's got some defunct mitochondria, some endoplasmic reticulum. And when that happens, we're going to get degradation and recycling of metabolites. So everything is good. We've metabolized our complex substrate to its component parts. We're functioning very well. We can fuse with our autophagosome and regain our metabolites. Now let's see what happens when we have a deficiency. So here we have our complex substrate, or say our GM2 ganglioside. It comes in happily into the lysosome, and enzyme A is working fine, so our little blue molecules can be released, but we've knocked out enzyme B. All right, so this would be hexosaminidase A in the case of Tay-Sachs. And this substrate now is going to accumulate. And when it accumulates, this is, remember, primary storage, we're going to have this non-metabolized products that are going to lead to lysosomal dysfunction. So this lysosome all by itself is now just not happy, but it is also not functioning as well when it comes time for autophagocytosis. So here we have autophagosome that is going to bind, but because the lysosome is not working properly, we're going to get defective degradation of our intracellular organelles, leading to our secondary storage, the accumulation of toxic proteins and aberrant mitochondria, which are going to result in the generation of free radical cell damage and cell death. And so this is this is really the central image for you to understand lysosomal storage disease, why having a deficiency in an enzyme causes injury to the patient. Now I'm going to provide a background looking at one particular disease, which is Tay-Sachs syndrome, so that we can put this into the context of a patient, so you can see how this actually manifests. So as I mentioned, we have hexosaminidase A deficiency. GM2 ganglioside is going to accumulate. Now we see it in a lot of different organs, but as I mentioned, we tend to see our gangliosides in the central nervous system, so we're going to get a lot of accumulation in our neurons and retina, but we can also see it in our heart, liver, and spleen. Now, there are more than 100 mutations described, and they tend to disrupt protein folding or intracellular transport. And the consequence of this is we get the unfolded protein response. When the cell sort of looks around and it says, wait, I've got all these unfolded proteins, they're not functional, they're accumulating, this is going to cause proteasomal degradation. And these the products of this can be toxic substrates and intermediates, which will be damaging to the cell. So individuals with Tay-Sachs syndrome tend to present with motor weakness at 3 to 6 months. This progresses onto neurologic impairment, blindness, and death typically follows at 2 to 3 years. I want to focus on this GM2 ganglioside accumulation. So this is what it looks like. So looking at this, you can tell this is a neuron and it is stuffed right here with GM2 ganglioside. And you can see this neuron that is filled with all this is not going to be able to function very well. Here's another image from Robbins and Cotran Atlas of Pathology showing another patient with Tay-Sachs disease, again with these very foamy neurons that are not functioning as well. But the classic finding for this is not going to be on a brain biopsy. You'll probably encounter this in some sort of clinical vignette somewhere where someone talks about doing an ophthalmologic exam on an infant and cherry red macula, right? So that is the buzzword, that is the high yield topic people tell you. Let's try to understand it so it's not just a memorization, shall we? So here we have an image of the retina of a child with Tay-Sachs. You can see here pretty clearly we can see the normal retinal vasculature, but it's really obscured here by this yellowing. And here is the cherry red macula. It's not actually just the macula, it's the fovea right here in the very dead center of our macula. Here's another image from the Robbins and Cotran pathologic basis of disease, again showing this pallor around this cherry red area. Now what's making it cherry red isn't that we've added anything here, it's that we have blocked out everything that is here so we can't see the normal vasculature. Now why is this happening? Well, here is this absolutely beautiful image of a retina in an individual with Tay-Sachs. And you can see here in this layer here, it's been stained so you can see the GM2 gangliosides in these ganglion cells. These little plump red cells are chock full of gangliosides. What happens here? This is where the fovea starts. There are no ganglion cells in the fovea because this is where we get our best vision. So we're not going to have any ganglia there. And this is where you can see the difference here. So this is why this appears cherry red. This is blocking what you can see below. This is not blocking. Let's take a look at another accumulation. So this is Gaucher disease, and these are macrophages that are stuffed with glucocerebroside. And you can see here, this has had the classic tissue paper appearance. You know, I guess it's supposed to be pathognomonic. If they show you this in the appropriate clinical setting, you're supposed to be able to know this is Gaucher disease. You know, I think it's a little challenging. But let's put it into some context. So this is a disease that's due to glucocerebrosidase deficiency. You can flip back to that earlier map that shows where we are in metabolism. And so glucocerebroside is going to accumulate in our macrophages, and the macrophages are going to be very upset, and they're going to be churning out cytokines. And so here you can see, for example, in this bone, that we have a lot of reactivity due to these cytokines. This is what's referred to as an Erlenmeyer flask deformity, this funnel-shaped appearance of the diaphysis and metaphysis. And this is the bone involvement we see in type 1 Gaucher disease. Since about 99% of Gaucher disease is type 1, that would be the one I'd recommend you focus your time on. These individuals also get hepatosplenomegaly. Why? Because you have the macrophages in the spleen and the liver which are accumulating this glucocerebroside and becoming enlarged. Individuals with Gaucher syndrome type 1, this is compatible with long life. Now let's leave the central nervous system lysosomal storage disorders aside and move on to the mucopolysaccharidoses, which has to do with glycosaminoglycans. So as you're familiar, glycosaminoglycans are widely distributed. So they're in the extracellular matrix, joint fluid, connective tissue. So some defect in their metabolism is going to cause widespread effects. And so the defects will affect almost every organ. We get accumulation of a variety of our glycosaminoglycans, which you can see here, and particularly, as I mentioned before, abundant in the spleen and liver, so our hepatosplenomegaly. And the clinical presentation is listed here. We tend to get coarse facial features because of the mucopolysaccharides that are in the skin and the soft tissue, corneal clouding, joint stiffness, and intellectual disability. And again, the goal of this video is not to go through each of the different diseases and how they differ, but just to give you an overview of how these diseases present. So here you can see corneal clouding. This is an individual with Hurler syndrome. And here you can see a stain that highlights glycosaminoglycans. This is in an endothelial wall. This blue staining is showing all this deposition of these mucopolysaccharides. These are the coarse facies that we see this is Hurler syndrome here. This is Hunter syndrome, which is X-linked recessive. Now, to take us to our last disease so we can get an idea of how these present, this is a glycogen storage disease. And the one that we're talking about in this particular video has to do with, is a lysosomal storage disorder as well as being a glycogen storage disease. So this is Pompe disease, and it's due to a deficiency of alpha-1,4-glucosidase, formerly known as acid maltase. So this is a lysosomal enzyme which catalyzes the breakdown of glycogen into glucose. Without this, glycogen can't be broken down and will build up. So we get a generalized glycogenosis with some hepatomegaly, massive cardiomegaly, and some hypotonia, because these are all organ systems that either metabolize and generate glycogen or that use it as fuel. And patients with this disease tend to have cardiorespiratory failure by the age of 2. And then to show you what the morphology of this is healthy cardiac muscle here with abundant eosinophilic cytoplasm, chock full of protein. And by contrast, this almost fishnet appearance of cardiac muscle is due to each of these cells being stuffed with glycogen, which is optically clear. So you can see that these cells would not be particularly functioning very well as not being able to utilize this fuel. So before we leave this, what do we do for these patients? So there are a variety of different possibilities. One approach is enzyme replacement therapy. Is it possible to deliver this enzyme to the patient so that it can metabolize the substrate? A second approach is substrate reduction therapy, is a way we can shunt that substrate into another pathway and prevent its buildup. Gene therapy is being increasingly looked at and has some exciting options. Splenectomy isn't used as often. Back several decades ago, this was much more common because when you have splenomegaly, since the spleen's job is to collect and sequester platelets and dysfunctional red cells, you're going to end up with thrombocytopenia and anemia. So if you remove the spleen, it can no longer do that, but then patients are at increased risk for infection from encapsulated organisms. And then a definitive treatment is hematopoietic stem cell transplantation. This will actually cure the patient, but there is significant morbidity and mortality, so this is not done very commonly. As always, I'm going to finish with a couple of questions that you can look at. Go ahead and pause this, see if you can answer these questions. If not, watch the video again. As always, thank you for your time. Please follow me on Twitter. I'd appreciate any comments that you can put down below. Thank you very much.